Michael Moore, the director of CME for Sovah Health in Danville and Martinsville, and along with Mary Kent, our CME coordinator, who's on the call, and Jennifer Goodman, who is one of our nurse educators and helps us manage these programs. We welcome you this evening to a program on a terribly important public health issue in Southside Virginia, and in fact in the entire Commonwealth, that being of the increasing prevalence of syphilis and its complications. The program this evening, I wake up my computer here, sorry, provides 1.5 hours of Category 1 Physician AMA CME and 1.5 hours of Virginia Nursing Association's CE credit. We increased the amount of credit from our program announcement when we saw the materials that Dr. Bracco has. They're just great, including case studies. We wanted to be sure there was enough time for her to delve into these in a very effective and appropriate way. Sovah Health is accredited by the Southern States CME Collaborative, which includes the Medical Society of Virginia, to provide Category 1 CME credit for physicians. It is also accredited by the Virginia Nurses Association to provide nursing CE credit for nurses and nurse practitioners. This program was developed to promote two desirable physician attributes, and that is providing patient-centered care and are always using evidence-based medicine in our practice. It came from a very profound public health care need, which Dr. Bracco detailed to you a little bit more as we get into the program. Dr. Bracco, myself, and members of the Sovah Health CME committee have nothing to disclose. Mary, I think you need to mute everybody. Somebody's got a live mic. There is no commercial support for the program this evening. Instead, it is supported, as are all of our Sovah Health CME programs, by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology Clinic, also known as the Danville Urologic Clinic, upon his retirement made a significant contribution to provide ongoing medical education in our community. And this was not only for physicians, but includes nurses, dental professionals, as well as EMTs, pharmacists, and other healthcare professionals. This evening, after the program, or you'll receive by email or you can activate a QR code in the chat that Mary will put up at the end of the program, you'll receive an evaluation form. We do ask you to take a few minutes and fill this out. It has some 7 questions, number 4 of which is, what changes do you plan to make in your practice based on this program this evening? And this is for everyone. This is not just for physicians or nurse practitioners. We all practice our healthcare skills within our scope of practice. So take a few minutes, answer the questions for us. It's terribly important for us as we evaluate programs and plan for future programs. That form that you'll receive, the eval form, also asks that you re-enter your name and your email. Please give us your full name, in as much as this is the name that will appear on your CME certificate. So no cute names, short names, abbreviations, if you will. If you're sharing the program log-on tonight with someone else, please email one of us and let us know that so we can give credit to those that attend. The eval form is not necessarily required for CME credit by the physicians, but it is required by the Virginia Nurses Association for nursing or nurse practitioner credit. So if you're in the latter, be sure you send in the eval form, and we hope everyone will take a few minutes to do that. Mary will put up in the chat box towards the end of the program a QR code that you can instantly access the eval form if you prefer that rather than receiving it by email. For the Sovah, we really need to mute somebody, Mary, if you can. For the Sovah Health medical residents, you do not need to collect your CME certificates. They will be sent to your coordinators, Dara Johnson and Lori Galvez, and they'll maintain a list of that for you. I'd like to take a moment, as I do each time we do a program, to particularly thank Mary Kent and Jennifer Goodman for the help in developing the programs. Without their truly tireless help, we would not be able to bring these programs to you. I know Dr. Baracco urges questions to be asked. You can place these in the chat, or you can raise your hand on the electronic little hand, or speak up, and she'll be delighted to address them. Once you've asked a verbal live question, please mute your phone to listen to her response, in as much as it prevents the feedback that occurs in our computer systems. Finally, I want to briefly highlight several really great upcoming CME programs we have scheduled. Next week, next Thursday evening, we're doing a women's health update with two CME faculty members from the Carilion Health Center in Roanoke. The first will be on the current modern menopause diagnosis and management, and the second on common female urogynecological disorders. These are two very, very good teachers, and I think the programs will be really helpful. And then our first Thursday night program in October is October 9th, and Neil Lewis, who is an attorney with the Hancock, Daniel, and Johnson firm, will be bringing a periodic medical malpractice in the state of Virginia update. We have had Mr. Lewis do this several times in the past. He'll talk about what new legislation is out there in Virginia that is regarding medical malpractice. And in addition, he will review the most recent, if you will, settlements or verdicts, and help us understand better approaches to reducing the risk that can exist for medical malpractice activities. All that being said, I'm delighted to introduce to you Dr. Allison Baracco. She is the medical officer for the Virginia Department of Health and Community Health Services. She actually resides in the Stanton, Virginia area, but she participates and provides expert advice and leadership to numerous health districts within the Commonwealth. Dr. Baracco began her educational journey at Auburn, where she graduated in biomedical sciences summa cum laude. She then went and did her MD degree at the University of South Alabama in Mobile, followed by internal medicine residencies and then fellowship in infectious disease at the Eastern Virginia Medical School. She has, during her career, held academic positions not only at Eastern Virginia Medical School, but also Mary Baldwin University and the Murphy Deming Physician Assistant Program, also Duke University Medical Center, and at VCOM, the Edward V. College of Osteopathic Medicine. We are delighted to have her do this, and I think you'll enjoy her lecture. So, Dr. Baracco, it's all yours. If you bring your slides up, mine should pop off, and we appreciate you doing this. Thank you.
Thank you. Mary Kent, are my slides up?
They are up, yes.
Wonderful. Is it it's in the presentation view?
Mm-hmm. Yep.
Okay,
great.
Wonderful. Because I have my own view here up on my screen. I figured all this out ahead of time. So awesome. Thank you, everyone. I'm delighted to be here to speak with everyone. I wish I could meet you all personally, but it's an awesome opportunity to share with you what we're seeing at the Virginia Department of Health. And one of my goals today is to empower everyone as far as the ability to diagnose and treat syphilis, which is a rising problem especially in Southwest Virginia. Through my work with the health district, the West Piedmont Health District, we've identified a disturbing trend and thought this would be a good opportunity to share some information with you. I don't have disclosures, any opinions that I might state, that they're opinions of my own, not the opinions of the state of Virginia or VDH, but this is a VDH slide set. I am very appreciative to the Office of Epidemiology and the STI division for providing a lot of these slides. I also appreciate Kay Shelton, who is the nurse practitioner for West Piedmont. She is the primary provider there for our health district for the Virginia Department of Health, and I know she worked with Dr. Moore to set this up. Dr. Spillman, thank you for the outreach to your community. I hope this is beneficial. We do have some sections where there's probably, I might explain explain what you have a question about. So we'll probably like kind of try to work through sections. And if there's questions in the chat, Mary Kent can get my attention. But please do ask them. I hope that we all learn from each other, and I want to be helpful. I jumped 2 slides. I apologize. So first, I want to start with a case study. I'm going to start with one of my very own case studies. So I moved to the Shenandoah Valley in 2011, and I'd been living in Norfolk before then for all of my training and then serving on faculty there. And when I lived in Norfolk, we had over 1,000 patients living with HIV. We saw syphilis, STIs, opportunistic infections. That was quite common. But then I moved to Stanton, Virginia, and had worked at a local community hospital, and we didn't see any syphilis. It appeared to be a trend that was more in the Hampton Roads area, but things are changing. And then we started to see kind of a trickle of cases. And in 2019, I saw a 50-year-old MSM, or man who has sex with other men, and he presented to the ophthalmologist with abrupt loss of vision. He was diagnosed with acute uveitis, and the ophthalmologist ordered a panel of blood work and identified that his syphilis, the treponemal antibody, was positive, and the reflex RPR was 1 to 128, and he was diagnosed with ocular syphilis. He also had headaches and some neurologic symptoms, was admitted to the hospital to receive 14 days of IV penicillin. His social history included that he had multiple partners, unprotected sex. We did screen him for HIV during the admission, and his test was negative. But that was a case that after that, we began to see kind of a series of syphilis cases, and it became a little more, unfortunately, a little more common in our area. So today we're going to kind of work through diagnosis, treatment, staging, and work through all the dynamics, and we'll get back to him a little later. But he did his ocular syphilis, his symptoms got better. So, treatment is effective for these situations. Now, when we think about the key facts of syphilis, it's a genital ulcerative sexually transmitted infection caused by the bacteria Treponema pallidum. And it's a spirochete. And so it can cause systemic disease, especially in the secondary phase of infection. It can facilitate the transmission and acquisition of HIV infection. So it's always important to screen someone for HIV when they are diagnosed with syphilis. Untreated syphilis in pregnant women can lead to infection in the fetus, 80% of cases, and may result in stillborn or infant death in up to 40% of the cases. And those that survive, unfortunately, can have lifelong defects. But the good news is that the reason why I'm here is syphilis is very treatable. We can prevent all of this. It's kind of exciting to present something where I can empower you to diagnose and treat things that you can actually cure and reverse and prevent these problems from happening. So primary and secondary syphilis has increased 2,140% across the United States. There's been an increase from 2000 to 2020. So here, for anyone that has their popcorn out, you might want to put it away for a few slides. We get into some of the graphic slides here that I have some pictures to help us look at the different stages of syphilis. So the one that we're most familiar with is a chancre. And that's primary syphilis. The average day that this appears is 30 days from the time that they were exposed to syphilis. And this is infectious. These chancres are just teeming with spirochetes. So if somebody has this, you're wanting to wear gloves with any kind of exam like this, but you have to know this is truly infectious. And during this first month through the first year period, there's a 30% risk of infectivity if somebody is in contact with someone with a syphilis. So this begins as a papule on a mucosal surface, and it ulcerates. It becomes hard and firm, and it's present for about 2 weeks. some people actually do have pain. So if you see someone with a single ulcer and they have all of the risk factors and they say it's painful, and we all learned in school it's a painless ulcer, you can have pain. Don't ignore it. It could still be syphilis. I mean, if it's a cluster of vesicles, that's more like herpes simplex. But we have to be cognizant, especially with these increasing levels of syphilis in the community. So then we move to secondary syphilis. This occurs approximately 2 to 8 weeks after a chancre has resolved, though you may see some overlap. And this is the period where there's hematogenous dissemination. And as an infectious diseases physician, I'll say that this is probably when I get consulted the most. People are sick, they feel lousy, they have a lot of symptoms, so I get consulted. There's rash 50% of the time, the palms and soles, lymphadenopathy, alopecia. These are some of the symptoms. I mean, everyone has a different variety of symptoms. You can see uveitis, aseptic meningitis or otic changes. Occasionally, you can even see elevation in the AST and ALT or a nephrotic syndrome. And those symptoms typically resolve in 3 months, though it can range 1 to 12 months. And a very small percentage of people could have a recurrence in the future. So when you look at these pictures, the top picture, you see, this is condyloma lata. It's the cauliflower or warty-looking lesions that are in the vulvar regions. You see a maculopapular rash on the palms in the middle picture, and that bottom picture is a rash of secondary syphilis taken from a journal. If you look at that closely, you could easily mistake that for like a viral xanthum. So we know syphilis is the great mimicker, and here we are again looking at that picture, and you could mistake it for anything, but that is syphilis in this scenario. Here's some more pictures of secondary syphilis and just a kind of a list of all the things you can see during that secondary hematogenous phase. Right. And then we move to tertiary syphilis. So tertiary syphilis is late syphilis. We typically see that 20 to 40 years after initial infection, and in up to 1/3 of untreated cases. The untreated infection can lead to endarteritis and complications including gummatous lesions like the one you see here in the picture. It can affect the skin and also the bone and be quite painful. Cardiovascular changes are rare, but it can happen where there's aortic aneurysm due to arteritis or aortic valve regurgitation. And then neurosyphilis. The late changes in neurosyphilis are meningovascular disease, such as endarteritis leading to a stroke. We see general paresis, progressive dementia, and tabes dorsalis is, I know, a buzzword that we've heard before, and that's wasting away the spinal cord, which leads to weakness. Right. So neurosyphilis can be seen at any stage of infection. So primary, secondary, tertiary, latent, any stage. So what you need to know is if somebody has acute vision changes, they need to see an ophthalmologist. Regardless of how you stage them, we need to know if they have ocular syphilis. If you have somebody who, has unexplained hearing loss or tinnitus or vertigo, also this rarely syphilis does cause otosyphilis. And then neurosyphilis includes a variety of symptoms. So if you have somebody with syphilis and you're taking a neurologic exam and they have neurologic abnormalities, and certainly we need to think about and assess for neurosyphilis, which typically involves a lumbar puncture. Right. So questions we can ask all of our patients. Now, reminder, these are not specific questions for syphilis. But if you have a patient who has a positive syphilis test, what kinds of things should we be asking them? We should be asking them about headaches, weakness, seizures, do you have difficulties with gait, memory, ocular syphilis, things about blurry vision, loss of vision, pain in the eyes, floaters, or for otic syphilis, have you experienced new onset hearing loss, tinnitus, and vertigo? So we have to take all of this information, what degree they're expressing of these changes, clinical context, their laboratory data, pull that all together to figure out what is this pretest probability that they have neurosyphilis, and do I need to think about a lumbar puncture in that patient? Right. So this is a summary slide about staging syphilis infections. We will be talking more about the staging again. We'll wrap it back in with the treatment later on in the slide set. But the two things that we didn't talk about with the picture slides are early latent syphilis and late latent or unknown duration syphilis. Now, early latent syphilis is when we diagnose someone who doesn't have symptoms but has a positive test result, and they've been diagnosed within 1 year of onset of an infection. Late latent, or probably what's most common is we have latent syphilis of unknown duration, is when somebody has had syphilis or the test positive for more than a year, or what we think is more than a year, or we just can't figure out when their test turned positive. And that happens a lot because people come for their first time testing, and maybe they had some risky behaviors and the RPR is positive, and you're like, what do I do now? It seems like syphilis of unknown duration. But we do our best to we have to do our best to tease that out. When you look at congenital risk, the risk of transmitting this in utero is most likely during primary and secondary, and it can be seen. It's likely in early latent and possible in that late latent because of that unknown, the unknown duration part that we just can't clear up. All right. So now I wanted to share with you all just a little bit about why am I here? Why are we talking about syphilis, and why do we need to think about it in Southwest Virginia? So this is a tale of a rural syndemic, and a syndemic is a cluster of 2 or more interconnected epidemics. And so we have our syphilis epidemic that's happening, and we have our opioid crisis that's happening, and substance use disorder that's happening. And those things have kind of merged, especially in our rural regions. So syphilis has been on the rise in Virginia. And what I'm going to show here with our West Piedmont data is that our demographics are changing. And so instead of flooding you with slides of data from I know I'm speaking to some Dan people and some people from West Piedmont, and then probably people from other places in the state, we're really just going to focus on the story of the West Piedmont Health District. So at first we'll talk about Virginia. So syphilis in Virginia. Up until the last year or so, VDH largely only presented data about early syphilis, but they did start presenting data about the orange color is late and unknown duration of syphilis, which what we're kind of learning is we think some of those unknown duration people, they really probably are early. We just couldn't figure out when they got it. They're probably still infectious and they're spreading. So in 2021, there were 2,243 cases. Now we're up to over 3,000 in 2024, which is an increase of 49% in the past 4 years across the state. This is similar to the national story. We're not that unusual, but if we're thinking about our state, how can we make things better here in Virginia? And when we look at West Piedmont specifically, which is a rural health district, what is disturbing is when we look at the trends here, syphilis in West Piedmont has increased. Syphilis cases of late and unknown duration have increased 112.5% between 2019 and 2024. And early syphilis cases, so that's primary and secondary cases, have increased 812.5%. So when we look at what's happening as far as the stages by sex at birth, this is the interesting story. So we had In the early 2000s, when HIV epidemic, we started to have really great HIV medications, and people started to be able to, most people became able to live with HIV because of our highly active antiretroviral agents. We then began to start to see syphilis rise again. And with the development of HIV pre-exposure prophylaxis, or PrEP, HIV PrEP, the number of syphilis cases in our MSM populations began to rise. But really, that was one of people living with HIV, people that did have high-risk behaviors on PrEP. Those were the people that truly we were seeing the majority of syphilis cases in. But then, as you can see here, in the early 2000s, with this rise in syphilis across the nation and in these rural areas, you can see that the number of women that are now becoming infected and they are in heterosexual relationships has significantly been rising. And why are we concerned about this? This trend is concerning because it can result in babies being born with congenital syphilis or syphilis acquired during pregnancy. The key points I want to share with you about the 2025 year-to-date data is that 57% of our cases in West Piedmont in 2025 were among women, with, again, that concern for congenital syphilis, miscarriages, and stillbirths. And other trends that we noticed is that 47% of the cases in 2025 self-reported that they'd been incarcerated in the past 12 months. Also, a significant portion of these people self-reported substance abuse or substance use. The age is primarily all age groups over 20, especially age 20 through 49 years old. And cases have increased in all counties in 2024 and 2025, but especially Henry and Franklin County. So when you're thinking about, who should we be concerned about, I think this data is kind of telling of what we need to think about in our rural areas of Virginia. So looking at the Virginia congenital syphilis trends between 2013 and 2023, we've also seen a significant increase. There was a 90% increase in congenital syphilis cases in Virginia from 2018, where there were 11 cases, to 2023, where we saw 21 cases. Previously, you see those low numbers in like 2013, 2014, 2 cases would be considered a bad year. But now the trend, unfortunately, is telling here. All right. So when we look at the VDH syphilis data dashboard, unfortunately, in the Southwest region, there were 5 cases in 2024, and there are already 2 cases in 2025. West Piedmont has had 4 cases of congenital syphilis. So this is one of our action plans, is just as far as education, because if we share with people we need to do more testing, we hope to help eliminate this problem. So in November 2023, the CDC released a new vital signs report focused on congenital syphilis in the United States. And the message is think early universal screening and early treatment. Because this problem that we're seeing, again, is not unique just to Virginia. But if you look at the data across the United States, there were only 335 cases across the country in 2012. And it's increased to 3,761, which is astronomical in 2022. The reason why we emphasize and bring this up is the increasing rates of syphilis among babies reflect a failure of our U.S. health system. These are all completely preventable cases of congenital or newborn syphilis, because if a woman is fully treated within 30 days before the child is born, then we can prevent congenital syphilis. This report finding shows that 88% of our cases could have been prevented by timely testing and treatment in the United States in 2022. The lack of prenatal care was a major cause of congenital syphilis in the United States. Sorry. So my final slide about congenital syphilis, timely testing and treatment is necessary, and it could have prevented 90% of cases of congenital syphilis. 2 in 5 cases of babies born with syphilis happen in people who did not receive prenatal care. All right. So I know some people are thinking, well, if we don't see them, how are we going to treat them? But we're going to have to get creative. So looking at what else can we do? We're going to look at updated CDC screening recommendations. And my recommendation is, when in doubt, screen. But we're going to look at the state of Virginia and talk about who should be screened. So we should be offering syphilis screening to all sexually active people ages 15 to 44 who are living in counties with high syphilis rates. And these are counties where the rate of primary and secondary syphilis among women aged 15 to 44 is greater than 4.6 per 100,000. So Virginia has 41 localities, counties, or cities that have elevated levels. And in those counties, we should be screening everyone. In counties with rates below the threshold, we consider individual risk factors. So I wanted to share with you this map of Virginia, and you can kind of see where all the orange. It's interesting. I live in a county that's orange, and it kind of tracks the whole 81 corridor, and then it goes past Roanoke, and then you get to Franklin County, and then Henry County. So that's that's part of West Piedmont District. Now, right next door, I see Pitt Dan is blue, but if you look around Pitt Dan, it's all orange. So if you're surrounded by a sea of orange, I just have to believe that there's no walls or fences surrounding this whole county. So, you're at high risk, I think, as the surrounding counties, and we probably should I would be more inclined to just be apt to test everyone rather than trying to weed out, or everyone who we need to, rather than to tease through risk factors. But specifically for those that are in those orange counties, we should be offering syphilis screening to all sexually active people aged 15 to 44 that live in counties with high syphilis rates. Also, we should be screening all pregnant women for syphilis during the first trimester. Typically, that's during their first prenatal visit, rescreen early in the third trimester, and then again at delivery. The latest ACOG, or American College of Obstetrics and Gynecology, recommendations recommend screening regardless of risk or where you live. And that, frankly, is much easier to do. Universal screening with opt-out testing has always been a better approach, or an easier approach, than trying to tease through people's risk factors. Now, people that live in those blue counties or localities, we assess individual risk factors to determine screening needs in those areas. And those would be like men who have sex with other men typically get screened at least annually, or more frequently if they have higher risks. Men who have sex with women that increase risk, persons with HIV, transgender, and then women and risky relationships, or again, the pregnancy. It's kind of baked into when you need to get it for pregnancy. All right. So now we get to a little more weighty of a topic, but I hope to make it more simple for everyone. And hopefully I don't get tongue twisted here, but testing and diagnosis frequently hangs some people up. If there are any questions, Mary can, from the previous material, I could take them, or I can and keep going. There will certainly be time for questions.
I'm not seeing anything in the chat right now.
Wonderful. Okay. So testing. I think one pearl everyone should know is that typically, regardless of how you're testing someone, there's going to be a two-step test. So if someone says they're positive for syphilis, there's got to be some reflex of one kind of test or another kind of test, and that's what we're going to spend some time on. Point of care testing is commercially available. It's available for people to do in their home. It's like by a finger stick. Also, some clinics are doing it. It is a treponemal assay. So before we dive into the blood test, we'll talk about primary syphilis testing. So false negative serologies are possible early in infection before antibodies have been able to develop when somebody has a chancre. So if you see a chancre or think it could be a chancre, you're going to treat them. It doesn't matter what any test says. You should just go ahead and treat them. RPR and VDRL tests can be 62 to 78% sensitive when you're diagnosing primary syphilis. The gold standard has always been dark field microscopy, but even academic centers have stopped doing that test. And frankly, I think if I saw a chancre, and that bottom picture there is a chancre in the vulvar region, if you see a chancre, then you're going to want to treat it, even if you had the ability to do a dark field microscopy test in your office. I would still want to treat that because I'd be uncertain of my, point of care laboratory technique. So to me, I don't find a need to have this test. You still do need to get blood work, even if it's negative, and follow through with that. And in patients with negative serology, but have a strong clinical suspicion, you can repeat those serology 2 to 4 weeks later to confirm the diagnosis. But, if in doubt, for these circumstances, you should be treating. All right. So in 2024, the CDC did provide laboratory recommendations for syphilis testing. It's a great bedtime read. I think it's a nice lengthy read that can put you to sleep, but it does have some useful information in it. And as I said, I hope to make this easy, but if it's not, we can entertain questions. So, along with a laboratory diagnosis, you have to always use the combination of what's happening clinically with this laboratory diagnosis, and you're going to use both treponemal and non-treponemal tests to differentiate between active infection, prior infection, and absence of infection. The serology of syphilis employs there's two different algorithms, and there's a traditional screening method. This is where a non-treponemal test is performed first, and then a treponemal test. So non-treponemal is like an RPR and a VDRL. And I've got more slides, don't worry. The reverse sequence is a screening method that more and more hospitals or lab centers are being able to use because the treponemal antibody test platforms have become much more accessible to like community hospitals. And I was always familiar with the traditional screening method, but probably about 5 years ago or so, the hospital in my health district, the community hospital, switched to the reverse sequence. So you can ask your lab director, honestly, as we work through this, if there's specific questions about what's happening in your hospital, your lab director should be able to help you with that. So non-treponemal tests. Non-treponemal tests detect antibody produced in response. It's an inflammatory response of our body's cell rather than a direct response to a spirochete. So it's responding to the inflammation created by the spirochete or the treponema. And what that means to me when you're creating an antibody against your own cell's inflammation is that it's probably not as specific as you'd like it to be. You're going to see false positives, and in fact, we do. You can see false positives due to other infections, autoimmune conditions, vaccines, pregnancy, older age, a whole host of, and sometimes you don't know why. But an RPR, for instance, of 1-to-1 is not necessarily an uncommon thing. But we know these non-treponemal tests are very important in the algorithm. They also have a lower sensitivity than our treponemal assays. A benefit of a non-treponemal test is that we watch them, we follow them, we monitor them, and they typically revert to negative or non-reactive after you've treated someone over time. The results can be subjective. You really just want, my biggest piece of advice, and usually you're ordering from the same lab, is if you're following somebody's syphilis testing results, and they received an RPR, like certain labs do RPR and certain ones do VDRLs. You can probably tell my bias is I've always had labs doing RPRs, so I'm going to talk about RPRs. But you're going to be following that same assay over time. You don't want to flip-flop from VDRL to RPR. There's no reason. It's not going to make sense. And so it can be used to both monitor response and tell if someone has a reinfection. So our treponemal tests, those are antibodies that are direct antibodies against the treponema. That makes more sense to me. It's like, okay, it's an antibody against syphilis. Okay, so there's few false positives, high specificity in this scenario, and there's fewer false negatives as well. It's more sensitive during early syphilis and late syphilis. Once you're infected, though, it remains positive for life. That's the hiccup or the hang up, is if somebody's had syphilis and you check them a year later and they have a positive test, well, is this untreated syphilis? Did you treat them fully? And this is just going to be the test they have for the rest of their life? What's going on? And that's where you have to put in all the clinical pieces. It cannot be used to monitor a response. It's going to be positive or it's going to be negative. And there are different assays, because occasionally as we work through these algorithms, you're going to see that sometimes you're going to have to check a second assay. But we'll get to that when we talk about the two different algorithms. All right. The serology timeline. Serologic tests vary regardless, or with or without treatment. That solid purple line is your treponemal antibody, and you can see it typically starts to increase within 2 weeks of exposure to syphilis, and then it stays positive. And once it stays positive, it stays positive for the duration. While the dotted line, the non-treponemal antibodies, so your RPR or your VDRL, with no treatment, it can drift down. Actually, I'm surprised, the note in this particular graphic, the no treatment line stays pretty high, considering that some people actually, if they've had syphilis for 20, 30 years, over time, that RPR or VDRL can drift down or become non-reactive. Somebody who's been treated and seroconvert, you can see that steep line decrease. And then some people end up, regardless of treatment, they could still have a RPR or VDRL that's positive for life, but typically it's like 1-to-1 or 1-to-2, and it's something you're following over time. And we'll talk a little more about that in a few slides. All right. So we look at our traditional testing algorithm. So traditionally, until more recently, it was typical that you would check a RPR or a VDRL as a screening test, a quantitative one with the titers. And if that's reactive, it would then reflex. And most labs, this is the question for your lab manager or wherever you're ordering the lab, do you reflex that so your patient doesn't have to come get another blood draw? And the vast majority of labs do this reflex for both traditional and the reverse sequence, with one caveat that we'll talk about with the reverse sequence. So you have your non-treponemal and it's reactive, you have to get that second treponemal serologic test. If that's positive, then syphilis is likely. Then you need to dig in the history. Have they been treated? Is this new? Is it latent? Do they have other symptoms? You have to go down that rabbit hole. If your TPPA is non-reactive, then syphilis is less likely, especially if it's like a 1-to-1 RPR and not really a strong history. Now, persons with a reactive non-treponemal test, you should always reflex it. You shouldn't just assume, well, could that be a false positive? You should reflex it each time. The reverse sequencer testing algorithm is when you start with a treponemal antibody test. And then if the treponemal antibody test is positive, then you're going to get a reactive. You get a non-treponemal, that RPR or VDRL with titers. If it's non-reactive, then there's no evidence of syphilis. But if you have concerns for primary syphilis, if the chancre is there, just ignore your test results and treat somebody, and then you can do all the follow-up testing later. So if your non-treponemal test is positive, like RPR is 1 to 64, bingo. Then you're going into that clinical assessment. Do they have syphilis? Is it old syphilis, new syphilis? What phase of syphilis? If it's non-reactive, this is the thing that some labs test and some don't, and you have to chase them down. But you can always talk to your lab manager if your health system doesn't do this and say, can't you just reflex it a second time when you get into this scenario where the treponemal test is positive, your non-treponemal test, your RPR is non-reactive. Those people need a second treponemal test, a different one, not the same one that they had before. So maybe they had a home test up here. Then in this circumstance, you would get the second one that they haven't, a different assay that they haven't gotten before, to make sure, to assess whether they have syphilis or they don't. If there was a risk and there's still concern, you can repeat the RPR several weeks later. So that's the gist of the two algorithms that can sometimes cause a little hiccups. Our non-treponemal test titers over time. This is a VDRL or L titer over time of untreated syphilis. You can see in late syphilis, this is an old slide, but this shows that over time, typically that does decline even if somebody's not been treated. And in 25% of people, it can revert to negative. Right. When we're interpreting titers, I'm going to ask you if we're on the phone together, did this, okay, what's if the RPR is positive, I'm like, what's the values? And okay, we checked it in June and the level was 1 to 16, and then we checked it again 6 months later, and now it's 1 to 32. That's considered a twofold increase. What's mostly clinically significant are for fourfold increases and fourfold decreases. Those are concerns of when it increases by fourfold, you're going to be worried about a reinfection or inadequate treatment. But if somebody follows the actual treatment guidelines, I mean, I never say never, but failure of treatment is very rare unless you've misdiagnosed what stage of syphilis they're in. You didn't do a neurologic exam and you gave them just one benzodiazepine injection and they really had neurosyphilis. But the vast majority of times, if we're clinically assessing right and treating them right, you shouldn't be seeing these increases. Right. Find a little bit about diagnosis before we all get glazed over. A cerebrospinal fluid evaluation. So if you're concerned about neurosyphilis, they're going to have to get a lumbar puncture. So we talked about the neurologic questions to ask. There has been a debate. If you have someone with ocular syphilis, do they need a lumbar puncture? If they don't have any other neurologic symptoms, the syphilis experts, and I just attended a rural STI course, are saying no, they do not need a lumbar puncture if they exclusively have ocular syphilis. They do need 2 weeks of IV penicillin, but you don't need to chase them down for a lumbar puncture. But they do need one if they do have neurologic symptoms in addition to their ocular syphilis, or if they have neurologic symptoms that are independent of whatever else is happening, like a cranial nerve dysfunction, or other abnormalities. A reminder about ocular syphilis, I can't say it enough. You need to partner with your ophthalmologist. They need to see an ophthalmologist if you're worried about that. All right. So I think the diagnostic part is the most weighty. If there's a question related to diagnostics that you feel lends itself to being answered now, I can do that. Our next section is treatment, where we're going to kind of link, where we are clinically and with diagnostics into how we're going to now treat these folks. So any questions, Mary Kent?
No questions, Allison Baracco.
Great, thank you. All right, so moving into...
Dr. Barco?
Yes.
Yes, Dr. Moore. I was just going to make a comment. We've got a lot of residents on the call, and one thing they might want to be aware of, this often comes up on board questions, is there's only 2 classic conditions that give palmar rashes, and those are, again, the secondary syphilis you talked about and Rocky Mountain spotted fever. So if you're taking a board exam and they show you a palm with active lesions, particularly the type that she just showed you in the previous slide, remember to check for syphilis. So thanks a bunch.
Thank you. That's awesome. And so next time you see someone with that palmar rash and they tell you that they think it was a tick, you can do a little head tilt and be like, was it a tick? Or do we need to dig deeper? I would ask that we dig deeper, dependent on the circumstances. So now moving into treatment recommendations. Staging is important for our treatment recommendations. I see any conditions that will give false pauses for RPRs. Great question. Before I move into treatment, yes, there are so many things that will cause a false positive RPR. Typically, it's a low-level false positive. It's going to be a titer of like 1 to 1 or 1 to 2. If you see an RPR that's like 1 to 256, that's probably syphilis, but it's really those low level, and it's going to be things, there's multiple things that can trigger it. Pregnancy, autoimmune conditions, vaccinations, other infections. So when you see that, that's the important reason with that algorithm of why we're checking the box, always getting the next step in the algorithm until we've kind of hit the dead end of where we've decided, is this syphilis or is this a false positive? So great question. Thank you. All right. So, go to slide 41 here. Okay, so syphilis treatment. This is not a memorize me kind of chart. This is information you can find on the CDC. As far as syphilis treatment regimens, the dosing, the duration. These are lookup questions, but it's important to talk about them so your mind is like triggered, like, oh yeah, she talked about that. Let me click on this to make sure I have the right dose, the right duration. When we have adults with primary, secondary, and early latent syphilis, they receive 1 single dose of 2.4 million units of benzathine penicillin, not any other kind of penicillin, benzathine penicillin. So that's one little thing you should have in your brain. There's a lot of different formulations of penicillin, and you're like, gosh, I can't remember which one. I'm going to look it up. For pregnant women, there are no alternatives. They have to receive penicillin. That's a board question too. For other patients with penicillin allergies, or if there's circumstances where they just need medicine and benzathine penicillin is not available, just looking at your scenarios, doxycycline, 100 milligrams twice a day for 14 days would be your alternative. Adults with late latent syphilis or syphilis of unknown duration get 2.4 million units a week for 3 weeks and 7-day intervals. So that becomes a big thing because we'd love to figure out what those unknown durations really was. It less than a year, or do we have to give them 3? Because follow-up can be problematic for some of these patients when we're thinking about some of the risk factors I pointed out earlier. The alternative, again, pregnancy, none. For others, doxycycline for 28 days is the option, which can be a little trying for people to complete. Neurosyphilis, ocular syphilis, otosyphilis, and again, those can occur in any stage of syphilis. They need 10 to 14 days of IV penicillin, either continuous drip or the dosing is every 4 hours, so it's a little tedious, but they require 2 weeks of IV penicillin. Okay. The alternative, I've never used procaine penicillin. I've never been able to get that plus the probenecid. That could be an option in your area. But just think, gosh, they have those things. I'm going to have to think about how we're going to administer 2 weeks of IV antibiotics. All right. Treating syphilis during pregnancy. Penicillin G is the only known effective antimicrobial to treat fetal infection and prevent congenital syphilis. That is really what you need to know. And again, we've talked about the highest risk of this occurring during the primary and secondary stages of syphilis. So they don't need 2 weeks of IV penicillin necessarily. They could get the benzathine penicillin injections, but they need penicillin. So if they're allergic, your board question says desensitization is recommended. I do have a little bonus case at the end where we'll talk a little bit about penicillin allergy very briefly. That could be an own topic on its own, but we'll hit a highlight on that in just as a teaser in a few slides. So why do we care? A lot of reasons. We talked about the morbidity and the mortality in infants, and that's really tragic. But if we don't treat these pregnant women appropriately, and the baby is born with congenital syphilis, here is the whole host of tests and treatments that poor infant may need to undergo. So yeah, this is again, nothing that you have to memorize. You just need to know why it's so important to treat pregnancy as soon as you can. It's just, you shouldn't try to wait. If somebody has to wait to see an OBGYN, they need treatment before they see the OBGYN, because we don't want to sit on the syphilis diagnosis. Additional treatment considerations, the Jarisch-Herxheimer reaction, that's another common test question, is what is that? That's basically the body's inflammatory response to all the spirochetes, lysine, and the treatment reaction you can see within the first 24 hours of initiating any syphilis therapy. That is not an allergic reaction. Do not put penicillin allergy on their chart if they have the Jarisch-Herxheimer reaction. Standard benzathine penicillin is recommended for primary, secondary, and latent syphilis. Again, benzathine procaine penicillin is not appropriate. So just make sure you're ordering the right thing. It's a lookup thing. It's not a memorized thing. Alternative treatments are available for people except during pregnancy. Right. For providers here, there was a benzathine penicillin shortage that lasted quite a while. It was a few years ago. And the Virginia Department of Health, because of the syphilis trends and some issues acquiring this medication, did create a resource to help link clinicians that need, the prioritization is for community clinicians who diagnose pregnant women with syphilis. If that's something that you may have patients that could be pregnant, it's worth looking into this resource. If you do not have access to benzathine penicillin, your friends at the local health department can at least help point you in the right direction or help talk to the right people if you need this resource. As this could help expedite treatment and decrease the number of patients you have to refer to the health department. So some little pearls about follow-up. We talked about when you need to order a central nervous system evaluation. Anybody who diagnosed with syphilis needs that RPR or VDRL, non-treponemal testing, after treatment, 6 and 12 months for primary and secondary, or 6, 12, and 24 months for latent syphilis. You're following those titers. And you're going to be worried that they've been reinfected or have had a treatment failure if you observe a 4-fold increase in serology that persists for more than 2 weeks. So, and you're always going to want to retreat and screen for HIV if you need to. So the people, I spent a long time in my infectious disease fellowship going through scenarios about this 4-fold increase in serology titer. Typically, we worried about it in people with uncontrolled like HIV. It is not common unless someone's been reinfected or didn't take their medicines as they were supposed to. But if somebody has a 2-fold increase, you basically just monitor and you're going to check them again at the next interval. I do not recommend testing people at 3 months because their titers, it takes time for people's titers to decrease. So if somebody comes in and they're really sick and their titer is like 1 to 256, when you check their titers in 6 months, do not expect them to be non-reactive. What is appropriate is in the first year after treatment, they have a 4-fold decrease. So you may only see it go down, usually see it go down more, but if it went down from 1 to 256 to 1 to 64, that would be considered appropriate. You're going to keep just monitoring their titers. But overall, most people, especially if they're HIV negative, typically get down to 1 to 2, 1 to 1, and non-reactive within the first year of treatment. That's my experience. But it can be a little more complicated when you're dealing with immunosuppressed hosts. So other management conditions, it is 8. We have some more slides. I know Dr. Moore gave me more time, and I am truly appreciative because I'd like to talk about, I don't think it will take a full 30 minutes, so you guys are in luck. But it's important to talk about the comprehensive approach that we need to take when we're looking at a syphilis patient. So I will highlight my case study again. Remember way back at slides 1, 2, and 3 when I talked about my 50-year-old who I diagnosed, or he had ocular syphilis, and I took care of him in the hospital and then in my clinic after and he received 14 days of IV penicillin. His vision got better. He was non-adherent. I tried, I knew the data about people who get syphilis, what their risk of HIV was, and I was really worried about him. We talked about starting HIV PrEP therapy because he had extremely high-risk behaviors, and this was my best attempt. He was very non-adherent, even to getting my follow-up titers. And the sad story, but I feel it's important to highlight because it does signal, it's a signal of the data. 2 years later, he was referred back to my clinic for his new HIV positive diagnosis. So in one study, this is one study, and there's different populations and different rates of HIV acquisition. But in this particular study in 2014, it's quite alarming. The risk of subsequent diagnosis of HIV infection within the first year of diagnosing syphilis was 3.6%. And then 10 years after syphilis diagnosis, 17.5% of those patients acquired HIV. So we have to think more broadly than just treating their syphilis. What are their continued risk factors? What can we help to mitigate those in the future? How can we prevent HIV? If this is an MSM or has other high-risk behaviors, which includes women that will continue to have non-monogamous sex and is unprotected and just high-risk behaviors, we can think about HIV PrEP therapy for them. So anyone that's diagnosed with syphilis at any stage should receive an HIV test. We also should consider checking syphilis serology for people diagnosed with Mpox, but also, again, look at risk factors and see, do they need vaccination for Mpox? That can turn into its own lengthy second own presentation. So we won't go into details other than I need you all to think about that. Also, I need to share with you DoxyPEP. Not sure how many people are familiar with DoxyPEP. DoxyPEP is doxycycline, which we use for post-exposure prophylaxis to prevent bacterial sexually transmitted infections. It has been shown in cisgender men who have sex with men and transgender women. You can see the numbers here to significantly decrease the risk of syphilis and chlamydia, as well as gonorrhea, but the real highlights are syphilis and chlamydia acquisition among people taking HIV PrEP and those living with HIV was what the study was. And what this is, it's the first prevention tool to prevent these bacterial STIs that's been found to be effective and well tolerated. So for people with condomless sex, you can prescribe, a prescription for DoxyPEP where they take 200 milligrams of this medicine and give them, a supply of this, 10 pills, 20 pills or something where they have it available if they meet these risk factors to take 24 to 72 hours after condomless sex. Now, unfortunately, we do not have data for other populations, including women. You should use a shared decision-making model for the populations I discussed. And typically, the people that you target are people that have had one STI and are at risk for a second one. They have condomless anal or oral sex with at least one male or transgender female partner, multiple sex partners or sex with anonymous partners. Those are people that you could consider DoxyPEP for. Also, looking at our comprehensive approach to trying to eliminate syphilis, we have to manage the partners. And so people that have been exposed to early syphilis within 90 days typically get treatment. After 90 days, get testing. There's a lot of details here. I think the key thing that you guys need to take home is that we in the health department have a disease interventional specialist. I call them like a disease or STI detective that help to identify sexual contacts, link them to appropriate testing and treatment. So you don't have to worry about the testing. I mean, that can be really a mental burden just to think about. It can be a little overwhelming when you learn from the person you've just diagnosed with syphilis about the people they may have infected. You don't personally have to reach out to all these people, but what is important is that you help, this is mandatory reporting, report through this confidential morbidity report form. There are alternates, fax or mail, I'm going to flip to the next page because it's nicer. But you are required, every healthcare practitioner, healthcare facility, medical laboratory, community partners that have a VDH agreement are required to report reportable diseases like syphilis. And when you do that, then our disease interventional specialist can, crack the case, identify who's potentially been exposed, contact them, try to get them in for treatment so we can help prevent the problem. And sometimes they have really good information. They'll be like, this patient that you said you're worried about active syphilis, they were just treated like 3 months ago. They were treated over in the next county at the health department. And then it might be that RPR value that's still, it's still kind of high. Maybe that's just that they were treated 3 months ago and they didn't realize it. Of course, we have to, check the boxes. Were they adherent? What did they receive? Did they receive the right doses? But this is an important tool to help. You help us and we help you. It's one of those situations. So it's important to report, even if the lab does automatically submit lab reports. But when a provider reports, they can add, kind of what clinical stage they think the patient's at. The patient's symptomatic but refuses the health or testing. The healthcare reporter can report suspected cases, and DIS can help try to get the patient to consider or agree to testing. And we just rely on this reporting. It's our ethical obligation as healthcare providers that we report all the reportable diseases. So here you have in the slides that you have the links if you need it. Our disease infection intervention specialist, the one in Pitt, Dan, and she goes to West Piedmont as well, is Denisha, and she is lovely, and she has helped so many patients. They are non-licensed public health professionals, expertise in case analysis, education, counseling, linkage to care, community engagement. She knows a lot about, she's not a healthcare provider, but she knows all the lingo about STIs. And so she is our partner. She is your partner too. She does all the contact tracing. So, I'm speaking about one person. They're all wonderful. Yours is phenomenal. Should be proud of what she does, but help her with that reporting piece. All right. So now we're just going to move on. I promise we'll be done. We'll be done by 8:15 with my part, and then we can take questions. I do have a bonus case. So we have a 32-year-old female. She presented the health department for a family planning visit. She reported normal menses until about 6 to 8 weeks ago, and you find out her urine pregnancy test is positive. You try to get her linked into care. She was last tested for STIs 1 year ago at the health department and denies any history. You decide you're going to get some testing, and her syphilis test reveals a treponemal antibody that's positive, and her RPR is 1 to 128. So you call her, you tell her the results, and her OB appointment is still 2 weeks away, and she is requesting treatment immediately, which is awesome, and you want to treat her. She reports a penicillin allergy. Okay, so now what are we going to do? So step 1. We're not going to panic. We're going to dive into step 1 of any penicillin allergy you see, especially on EHRs, is ask the patient what their actual allergy is to talk more about it. So our patient says, or her allergy is actually listed as diarrhea, and you talk to her more, and she states that her only symptom was mild diarrhea a few days after starting amoxicillin. She denies history of rash, shortness of breath, any concerning symptoms indicative of an IgE-mediated allergy. So what are you going to recommend? A, are you going to update her allergy list and mark it as an intolerance and educate her that diarrhea is not an allergic reaction, and then treat her with penicillin? B, say that her allergy history is low risk and recommend an allergy referral for an oral amoxicillin challenge. She is pregnant after all. We really don't want to screw this up. C, say that her history is moderate to high risk allergy history. Recommend allergy referral for penicillin skin testing. Consider D, this is an IgE mediated reaction, and she doesn't qualify for this referral, so we're just going to have to desensitize her. Let's admit her to the hospital. Or E, she has a non-IgE mediated reaction, and she should never receive penicillin. So, there's nothing we can do. All right, so I don't know if I can, it's hard, I can't really poll people. If anyone puts stuff in the chat, I'll see it pop up. But what is everyone thinking here? Or you can unmute. It's okay. I'm seeing some A's. All right. I like A too. That is A. She does not have an allergy. And this is important. I mean, the biggest take home of all this, I gave you like a very easy case, I think. I know there's a lot of more complicated cases, but I just wanted to highlight is when somebody says they have a penicillin allergy, the first thing to do is ask them more about it. Unfortunately, 10% of the population reports a penicillin allergy, but in reality, less than 1% of our population is truly allergic. So why do so many patients claim an allergy? It's challenging. A lot were told when they were younger. I mean, that's very common. My parents told me I'm allergic. In a study by Preston and colleagues, only a third of patients were able to describe their actual reaction. Another challenge is that patients are unable to differentiate between an allergy and an intolerance. 17% of patients claim to be allergic, but their reaction was something like nausea or an upset stomach. So it's important that we educate them and help them with understanding. Lastly, when we know that IgE antibodies responsible for penicillin allergies wane over time. It's estimated 5 years after a true IgE-mediated allergy, 50% of patients lose their IgE-mediated sensitivity, and 80% lose their sensitivity after 10 years. So really, the reality is we make a big deal, and we need to sometimes about. I'm not underselling that anaphylaxis is a big problem, yes, but we need to take the appropriate history. And if somebody needs penicillin and it sounds like they don't have an allergy, then we should be brave and consider, like, this patient. This is there are many gray cases, but in patients like this, we should just go ahead and treat them with penicillin. So there is a tool that you can use. I want to share this PenFast allergy decision rule. And there is a calculator on the web that kind of makes it easy for you to click all the buttons and get your answer. So this is indicated for patients who report an allergy to a penicillin or a beta-lactam. And the highlight of the tool is it has a high negative predictive value that makes it effective when you want to rule out penicillin allergy for low risk cases. Now, pitfall, if somebody has Stevens-Johnson or like a T-cell mediated reaction, kidney failure related to antibiotic, it doesn't cover that. We're talking about IgE mediated cases. But it helps identify who we don't have to jump through all the hoops of finding an allergist, getting skin testing, and doing a lot of things before they get treated, which can be important, especially when we're dealing with people where, time is important. We don't want them to infect others. We need to get them treated. So this is a snapshot of the tool. There's a calculator. Google, and there's more than one calculator, but that PenFast tool, it's going to tell, I'm trying to, okay, put my reading glasses on. So the questions to ask: 5 years or less since your reaction. Did you have anaphylaxis or angioedema, or did you have a severe cutaneous adverse reaction? And did you require treatment for the reaction? And It scores the points, and then it will tell you what the risk for a true penicillin allergy is. So I find that tool helpful, and not just for syphilis, but for any time you're considering using penicillin. So penicillin allergy delabeling in STIs. In a low resource outpatient STI clinic, they actually did evaluate using point of care administration or using a tool like the PenFast tool in an STI test, in an STI setting. And in this clinic, what they found was that 67% of their patients who reported an allergy were able to actually receive penicillin or a beta-lactam antimicrobial, which was the first-line treatment for their disorder. And there were no cases of anaphylaxis. That's another highlight. Most of the studies that have been performed now looking at, kind of more aggressively approaching this, no cases of anaphylaxis were identified in this particular study. All right. So I am not going to talk through the resources. I just want to share syphilis resource page for providers. Here's some other resources. We're a resource at the health department. We really just want to help eliminate syphilis. And if you have questions, we can help answer them. If we want you to feel empowered, if you have the capability to treat these in your office, that we support you. We have the resources, including our DIS, to help with that contact investigation. We're here for you, but also we would love to see this Southwest area kind of like stomp out congenital syphilis. Right. I appreciate everyone's time, and I'm happy to take any questions. Thank you.
Do we have any questions from anybody on the call? I might, I don't know if you can respond to this, Dr. Rockwell. We need Dr. Spillman or either Kay Shelton to respond about what are the specific availabilities here at the Danville, Pennsylvania Health Center in Danville or Martinsville. Either one of you on the call, Dr. Spillman or Ms. Shelton, want to speak to that briefly?
Well, hey, this is Scott Spillman. Allison, thank you so much, Dr. Bracco. Fantastic, and look forward to. Whoops, I guess you don't need to see my pens. It's working together more about this, and Denisha does a great job, and we really enjoy working with her. We do this testing, and we do some treatment. And when I sit down with my nurse practitioner every month to review charts, and even in between, it seems like almost every month we come up with a case, and various levels of latent case, old case. We don't usually see the late cases right now. We're usually seeing some. We have a question of were they completely treated, and versus partners that that had it, and should they where should they be? So we work with that. One of the things I'll just touch about penicillin for just a second. Back a long time ago, when I was a young country doctor in rural Colorado with my first public health with the federal government, I found that several people were allergic, had an allergy to a history of allergy to penicillin. But what I found out through some other combinations of testings and trial and error with some of them very carefully was that their allergy was really to more the vehicle of the penicillin rather than the penicillin molecule itself. In other words, what it was housed in that delivered the system, and in sending them, some of them to allergists, that seemed to bear out, as opposed to some of the newer penicillins they could take, as the older ones they had trouble taking. So for whatever that's worth, it was old time stuff. I was leaner then, and I had darker hair, and so for what that's worth, and maybe even Dr. Moore had darker hair back then. So, and again, thank you. Okay, you got.
Thanks, Dr. Spillman. Let me, Mary, are there questions? It looked like questions were popping up.
Dr. Moore, this is Kay. Both of our health districts have STI clinics, so all the patients have to do is call in. If it's something of an urgent nature by a healthcare provider, just call and ask for the nursing supervisor. We only have part-time in West Piedmont, but we do everything we can to get them in a timely manner. One of the things I wanted to point out is if you have an OB patient that's having to have the 3 doses of penicillin and she misses, like she's supposed to have like the second one on day 7, if she misses on day 10, she has to start all over again. She cannot just get that dose and then one more. It's a 9-day limit on pregnant people. Okay. Thank you.
Dr. Baracco, do you see Dr. Hona's question in the chat?
I do. So the question, I'll read it out loud, is do you treat low titer positive pregnant patient who's had a history of syphilis approximately 1 year ago? If actual infection is debatable, would you err to treat because she is pregnant? I think the answer, or I know the answer. So the answer to this is yes, I would err on the side of caution. If you can fully track and you're like map it all out and you're like, oh yeah, they received, maybe it was syphilis of unknown duration, and you looked at all the titers and it tracks, she got her 6-month and 12-month titer, it's all going down accordingly, and it all looks like, this is legitimate, she was treated, got what she needed, sure, then, case closed, you don't need to treat. But I think more frequently what happens is people sought care here, they did this, they skipped this lab work and whatever, and then, oh, boom, here they are in your clinic and they're pregnant. And now what do I do? Well, in the case of pregnancy, because we know congenital syphilis is so devastating, I personally would treat them. We could go into like zebra mode, and what if they had a history of anaphylaxis, penicillin, and we could get into the weeds with that. But I mean, in the vast majority, I think the answer would be pretty simple to just go ahead and treat them, unless you had clear documentation. Right. Thank you. Were there other questions? That was the one I saw.
That is the only one that I see.
All right.
Any other questions from any of the folks on the call this evening? This has been a really, really nice program, Dr. Baracco. Really well done.
Thank you. It takes a village. I have a lot of, the Virginia Department of Health as such a great support system, such a vast group of people that we work with between population health, the health director, epidemiology, or the disease intervention specialist, or folks at central office. We all work together to help you and provide these resources. So please do be friends. Don't hesitate to reach out if you need our help. So thank you.
And I would just point out, we have recorded the program this evening. It will be available through the Sovah Health website, although it won't provide CE or CME physician credit. It's still there for folks. If someone in your practice group would like to listen to it, which you hope they would, they're more than welcome. And if you have any questions about that, contact me or Mary or Jennifer Goodman, and we'll get you the link and so forth. Okay, well, thanks so much. We won't keep you past the time. Dr. Baracco stayed right on time. Thanks to Kay Lydia Shelton for bringing this to our group and bringing our awareness for Dr. Spillman's support, and of course, Mary and Jennifer. We hope you have a good evening. I hope you'll come back next week. We'll do women's healthcare, same day, same time, and we'll have the 2 talks that evening. So thank you for being with us. Have a great evening, and we wish you the very best. Bye-bye.
Thank you, Dr.